Think about the physical mechanics required just to look around a room. Your eyes are constantly darting, stopping, and tracking targets with mathematical precision. When you follow a bird flying across the sky, you're using smooth pursuits, the continuous, fluid tracking of a moving target. But when you read a line of text, your eye doesn't glide. It instantaneously snaps between distinct words. These rapid, ballistic jumps are called saccades. In a clinical setting, evaluating a patient's vision means testing both of these distinct physiological mechanics. The diagnostic challenge is that when these eye movements fail, patients subconsciously hide the deficit. They adapt by moving their heads, or their symptoms get masked by underlying cognitive delays. True oculomotor evaluation cannot rely on a single test. It requires a strict diagnostic pipeline, moving from qualitative physical observation to standardized grading, to isolating cognitive factors, and finally, recording objective infrared data. That pipeline begins in the exam chair with simple, qualitative observation using fine detail targets. To establish a baseline for smooth pursuits, the clinician asks the patient to track an engaging target as it is moved in a double H pattern. For saccades, the baseline test requires the patient to repeatedly jump their fixation back and forth between two distinct targets. During these tasks, the clinician is looking for specific physical errors, a lack of smoothness, the eyes overshooting or undershooting the target, and drops in accuracy when the patient's gaze crosses their midline. They are also watching for motor overflow, excessive head or body movements that the patient uses to unconsciously compensate for poor ocular control. While this observation detects gross physical errors, it lacks standardized metrics. Without hard numbers, it cannot serve as a reliable baseline for clinical grading. To advance up the diagnostic hierarchy, clinicians use the NSUCO oculomotor test to translate subjective observation into quantitative data. The NSUCO pursuit test enforces strict physical parameters, requiring the clinician to move a single target in a precise 20-centimeter circle. For saccade testing, the patient must jump their fixation between two targets held exactly 10 centimeters from their midline. Performance on these tasks is then evaluated using a mathematical standard known as the SCCO 4+ rating system. At the top of the scale, a grade of 4+ is awarded exclusively for completely smooth and accurate eye movements. A 3+ represents exactly one fixation loss or slight undershooting, while a 2+ indicates two fixation losses, or gross over and undershooting. A grade of 1+ denotes clinical failure and an inability to complete the task, more than two fixation losses, or uncontrolled motor overflow. By tying the score to fixation losses, the SCCO 4+ system solves subjective observation, transforming physical mechanics into an objective clinical baseline. Once baseline tracking is established, testing transitions to a functional simulation of the reading process using the King-DeVick test. The mechanics are straightforward. The patient reads numbers out loud as quickly as possible, from increasingly difficult test cards, without using a finger to guide their eyes. The evaluation relies on time. Clinicians record the errors and the total time it takes to finish, comparing the final score against age-matched norms. However, this entirely time-based method contains a hidden diagnostic flaw. Reading numbers aloud relies on a cognitive variable called rapid automatic naming, or RAN skills. A slow reading time on the King-DeVick presents two distinct possibilities. Either the patient has a mechanical saccadic deficit, or their eye muscles are fine and they are experiencing a delay in the brain's cognitive processing speed. If a test cannot isolate those RAN skills, clinicians risk misdiagnosing a neurological processing issue as an eye muscle dysfunction. The developmental eye movement, or DEM test, provides the specific mathematical solution to this cognitive overlap. The DEM test is structured using three distinct charts of numbers, two vertical columns and one wide horizontal grid. Because reading down a column requires almost zero horizontal movement, the vertical charts establish a pure baseline for rapid number naming and processing speed. The horizontal chart then forces the patient to heavily utilize saccadic eye movements to read across the grid. The clinician takes the results and calculates the DEM ratio by dividing the horizontal adjusted time by the vertical adjusted time. Since verbal processing speed is required for both, that cognitive variable mathematically cancels itself out in the ratio. This leaves the clinician with a single number representing only the true motor deficit, entirely independent of the patient's cognitive processing speed. By utilizing this calculation, the DEM test allows clinicians to definitively separate mechanical oculomotor dysfunction from neurological delays. The absolute peak of the diagnostic hierarchy requires removing manual human observation entirely in favor of objective, high-tech eye tracking. This is achieved using hardware like the Visograph 3, Readalizer, or iLink systems, which rely on specialized goggles equipped with infrared eye monitoring sensors. The patient wears the tracking equipment while performing specific visual tasks or reading text. The sensors provide advanced computerized data extraction, identifying exact fixations, microscopic regressions, and precise reading speeds impossible to count by eye. This hardware acts as the ultimate verification layer, permanently removing the margin of human observation error from the diagnostic pipeline. Once the diagnostic pipeline is complete, the resulting data dictates the clinical management strategy. We have tracked the process from qualitative observation to SCCO 4+ standardization, cognitive isolation with the DEM, and infrared verification. If those tests confirm an underlying oculomotor dysfunction, such as frequent fixation losses, treatment follows a strict hierarchy. Foundational optical physics must be resolved first. Correcting any refractive errors with lenses is mandatory before attempting to rehabilitate the visual system. Step 2 is the implementation of specific vision therapy activities. Clinicians utilize targeted regimens like letter tracking, saccadic pyramids, and Marsden ball activities. These therapies are designed to physically build eye movement control and neural stamina through repeated, controlled mechanical exertion. When a patient follows the arc of a Marsden ball, they are conditioning their extraocular muscles to maintain continuous, smooth pursuit control. This progressive diagnostic framework provides the clarity necessary to distinguish between a physical eye muscle issue and a deeper neurological delay, ensuring the final intervention matches the underlying cause.